Hello, the time is now 12:30 p.m. Eastern, the official start time for today's broadcast. The topic today is integrating care for the whole person. And now, without further ado, I'd like to turn things over to your host, Dr. Adrienne Mims, Chief Medical Officer and Vice President of Alliant Quality. Doctor, the floor is yours.
Good afternoon, and welcome to our program today. We are so excited that you use your time to be with us and learn more about how you can care for your patients. We have an exciting program here to share with you. I would first like to let you know about the free technical assistance that we provide here at Alliant Quality. Since you have signed up to be part of our Learning Collaborative, we can help you with resources and tools to improve your billing practices for depression and alcohol screening. We can help you understand where to refer to patients where you're not able to treat them, or how to manage them in the primary care environment. Join with us in our ongoing learning collaborative, and we can share these evidence-based practices. I'd also want to remind you about the available billing codes for screening for depression. Remember, Medicare pays for screening for depression on a yearly basis if it occurs in one of the codes that are listed there by the specialists that are listed on the slide. I encourage you to make use of these and make sure your patients are screened well for this condition. And today, I welcome our presenter, Dr. Paul Chesnowski. He has served in academic positions at the University of Washington for the past 20 years and continues to serve in an affiliate role as clinical associate professor. He's chief medical officer for Same Page Health, a company that he founded. It provides services and software for improving healthcare communication, behavior change, and patient engagement. He founded Training Exchange, a program at the Center for Commercialization at University of Washington. It provides national training and dissemination of evidence-based interventions for treating chronic conditions. He serves as a team psychiatrist and head of behavioral health for the University of Washington Diabetes Care Center for 17 years. And since 1997, he was the principal investigator or co-investigator on several clinical trials that were funded by NIH or CDC. His areas of focus is collaborative care for depression, diabetes and heart disease, epilepsy, and in the geriatric patient populations. He also received a Career Development Award through NIDDK on exploring the influences of attachment styles on treatment outcomes in diabetes. He's written over 100 articles, including numerous book chapters. Dr. Chesnowski has earned his medical degree from McGill University in Montreal and completed residencies in both family medicine and psychiatry. He currently serves as a member of the Community Leadership Board for the American Diabetes Association in Washington State. I know that you will be very pleased with what you'll learn from him today. His wealth of knowledge is here to be shared. Thank you. And I turn it over now to Dr. Paul Chesnowski.
Well, thank you very much, Dr. Mims, and I want to also thank Alliant Quality for this opportunity. And most importantly, I also want to thank all of you for taking time out of your day to participate today in this dialogue. We will have time at the end for discussion, questions. But today what I'm going to be talking about is about integrating care for the whole person, collaborative teams for behavioral health and medical conditions. The goals and objectives of my presentation today are to review core components of collaborative care, but specifically about multi-condition collaborative care. So not only focusing on depression, but focusing on multiple chronic conditions, medical and behavioral. I'm going to define clinical inertia as a concept that I think we should all know about. And then finally, I'm going to review the clinical trial basis as we review the components, the necessary components that need to be in place for providing this kind of care that really has been shown in multiple trials to address the triple aim, if not the quadruple aim of the CMS. So, you know, we've been talking about a lot of chronic conditions and really focusing on the whole person, particularly people with multiple disorders and conditions. I want to start by talking about the most important disorder of all. This is a disorder that's sweeping the nation, and I guarantee you that you're dealing with this disorder in your organization as well. And if we don't understand and start to deal with this disorder, then we are not serving our patients well or cost effectively. That disorder is called clinical inertia. It's an institutional disorder. And the definition of clinical inertia, if you haven't heard it, is it's defined as a lack of treatment intensification in a patient not at evidence-based goals for care. Furthermore, it's a major factor that contributes to inadequate chronic disease care in patients with, frankly, any chronic condition, including these listed here. And the way we know about clinical inertia is from some great studies that were done. Here's one by Schmittil and colleagues looking at 160,000 patients with diabetes. They went into this very thorough chart review, both electronic records, paper charts, and they were anticipating finding patterns of poor treatment adherence and poor self-management. They were surprised because they found that actually the majority of patients they had adequate adherence. The real problem was this lack of treatment intensification by the healthcare team. In other words, not recognizing what should be done, not using guideline level algorithms, not making recommendations in a timely manner, and then not closing the loop on those action steps. You know, in some ways, it's really like looking in a mirror. All the things that we expect from our patients as clinicians or as healthcare systems, which is that patients do the right thing, they follow the best treatments, that they actually engage in something, that they close the loop on those action steps so we can check the box that they're actually doing the things. Those very things that we expect of our patients, we need to start expecting of ourselves. And because of competing demands, because of limited resources, it's very, very difficult. We all know this. And yet I think this is a very critical thing that we need to look at. So I liken it to not only looking in the mirror, but maybe a two-way mirror, where we can both look at what we're expecting from our patients, but also see a little bit of a reflection and helping us understand that we too have a play part in this. This is the really looking at the ecosystem within which we're treating our patients with multiple chronic conditions. So as an example, what this might look like is this. Mrs. Jones here is coming to see her healthcare provider in earnest, 4 to 6 times a year. She has diabetes, hypertension, hypercholesterolemia, and depression, and she cannot get her ABC, A1C, B blood pressure, or C cholesterol in target. We call that the bundled benchmark. And when we look at national data, NHANES data, sadly, 81% of those with diabetes in this country fail to achieve that bundled benchmark. 81% of those with diabetes fail to achieve the ABC bundled benchmark. That's astonishing. And it's really a reflection of the fact that, as these authors say, that really to achieve this, healthcare systems require improved methods to improve adherence, medication treatment, physical activity, dietary choice, and so on, access to support, including motivation and maintenance of behavior change. So I ask, in a 7 to 15-minute visit every 2 to 3 months, how do we achieve this? How do we achieve this? And of course, there's all kinds of ideas and plans. And today what I'm going to tell you about is a proven plan that's been shown in dozens and dozens of clinical trials. In fact, now up to 80 clinical trials that have shown proven the concept, proven that it works. And there's some very exciting things that just happened in January 1st, just over a month ago, where there's a new physician fee schedule with new reimbursement codes for this, which I'll talk about both in the discussion, and I'll try to touch on it during this conversation as well. The other thing that you probably already know, but if you look at individuals with diabetes as an example, and look at those that also have untreated depression, the costs are about 2 to 3 times higher. Now, that's great for the CFO or for someone in the hospital who's worried about costs, but for clinicians, and I'm a clinician, for us as clinicians, we also want to worry about that because we can't get traction with our patients. Patients languish, and we are struggling to get the outcomes that we'd like with patients with diabetes. And don't forget, individuals with diabetes, 90% of them have at least one other chronic condition. And so very quickly you have polychronic patients with multiple chronic conditions that are languishing. We're not doing them any services by using our old model of, one patient, one provider every 2 to 3 months for people with 5 or 6 chronic conditions and on 15 meds, and we'll talk about that more in a moment. And I guess the only other thing I would say about that is that depression, the prevalence of depression in people with diabetes is about double what it is in people without diabetes, and you can look across chronic conditions and see similar patterns. So when we look at the epidemiological triangle, when we look at who we're really focusing on, it's not the generally healthy or even the rising risk, the pre-diabetics. We're looking at the complex chronic patients, individuals with multiple chronic conditions and what we now call upstream effects, social determinants of health. And those make up the top, between 5 and 10% of patients. And as we know, it's the 5-50 rule, 5% of patients that cost 50% of the healthcare dollar, or 10% that cost 2/3 of the healthcare dollar. And not only is this important from the standpoint of understanding where our resources are going, but the better we can be at reducing costs and being more efficient, the more money we have to address the rising risk and have preventative programs. These are national data I'm showing you here that really just show you the math. And so the solution that I'm going to talk about today is called collaborative care. This is an evidence-based program. As you heard in the preamble, I have conducted clinical trials with teams at the University of Washington and around the country looking at utilizing this model not only in depression care, but in people with hypertension, epilepsy, hyperlipidemia, hypercholesterolemia, and diabetes. It's a team with a shared mission using improved clinical systems to deliver improved care to a patient population supported by operational and financial systems. Such care is continuously evaluated through improvement processes and effectiveness measurement. Before I forget, I want to encourage you, and I've given a link to Align Quality, they'll have it up. There was a recent article in New England Journal of Medicine about the new billing codes for collaborative care for psychiatric care. It's about $140 per patient per month for the first month and $120 subsequently. It covers care management and psychiatric oversight. So keep that in mind. In that article, you will also find reference number 2 that goes right to the Federal Registry for the new physician fee schedule. And these are G codes, G0502 all the way to G0504. And I'll stop talking about it at this point, but I encourage you to look into this, and it tells you what needs to be in place. So the way this works is that if you think about the old model being, the PCP, the primary care provider, and the patient, I jokingly call this so 1990s, and actually it's so 1950s and 1920s. Really, we cannot continue to pretend that we're treating people with multiple chronic conditions with very infrequent visits and without any support. And we all know that. I'm sure this is not a surprise to any of you. So thankfully, we've layered on care management and extended the care, and now are focusing on between healthcare visits, addressing patients' needs where they are, which is the right thing to do. What we discovered in our 20 years of clinical trials, however, is that there's one other component, and that is called systematic case review. And in this case, what we're talking about is both psychiatric and medical case review. Now, you're probably thinking, my God, there's no psychiatrist anywhere, and this is going to be very expensive. And what I'll tell you right away is that this model actually just requires 2 hours per week for a whole caseload of patients, of 50 patients, of each of the psychiatric and medical case reviewers. 2 hours per week. And this can be done remotely, and so leveraging telemedicine, all kinds of various new technologies to do this. And what you're essentially doing is leveraging the use of those healthcare providers to review the caseload. And it makes all the difference. It addresses the triple aim, better quality of care and access to care, increases, I'll show you evidence about the outcomes that you achieve, and it reduces healthcare costs. We have evidence of that from our clinical trials. And we should also talk about the quadruple aim, which is it also improves the quality of caring. In other words, for all the burned out, demoralized healthcare providers out there, and I wish it wasn't true, but there's many reports, as you know, that are saying this is just becoming untenable. We really need to care for our healthcare providers as well. And so this system actually improves the quality of that experience of caring for these complex patients. So we published this a few years ago in New England Journal of Medicine. This was a collaborative care trial where we looked at people in 9 different clinics in the Puget Sound area at Group Health Cooperative. And essentially what we found is that with one care manager, in this case it was a nurse care manager, in the past we've used social workers, we were able to achieve the A, B, C, D, A1C, B, blood pressure, C, cholesterol, and D, depression as outcomes, and we were able to significantly reduce each of those. Here's just a little more detail on that. The shaded column shows the effect of our program compared to the right of the shaded column, which is the meta-analyses of any one of those indicators, like depression, just looking at depression, or just looking at A1C, or just looking at systolic blood pressure, whereas we looked in our trial at all 3 of these at the same time, and we were able to get comparable, if not better, results. I mean, the difference in depression care, taking care of people's medical issues, we had a 0.65 effect size. Effect size is a difference between means divided by the standard deviation, and that's a very robust effect size. We were also able to reduce LDL significantly, and at the end of the day, we saved $1,100 in lower outpatient costs. We did not report here on inpatient costs, and if we did, in subsequent analyses, it could be even higher if you just imagine what inpatient costs and ED visits cost. But here we were just looking at outpatient costs and the improvement there. Now, one of the mechanisms by which this works, if we think about it, is that it really helps to improve the adjustments that we make, the titrations we make in antidepressants, oral hypoglycemics, and insulin. I just want to show you this is in that New England Journal paper that we conducted. And as you can see, there's a significant improvement. This is the proportion of patients who had 1 or more medical adjustments in 12 months. And what you can see is that in the intervention, the blue bars, it was significantly better than control. But I think the real message here is that this was a great system of care, one of the best, and still what we find is that the antidepressants, people with major depression, only 30% of them had an adjustment in their medications in 12 calendar months. Or people with A1Cs over 8%, only 30% had an adjustment in their insulin. So in subsequent programs, in 17 to 24 weeks, in this case 17 and other examples, 24 weeks, not only were we able to improve A1C testing and reduce depression by 74% amongst this population, but we were able to increase the proportion of patients achieving HEDIS goals for A1C and blood pressure by 69 and 29% respectively, and without a transitional care program in place, but just by virtue of the contacts, we were able to reduce emergency department visits by 50%. That alone more than paid for a program in a value-based system. But remember, the billing codes that I told you about earlier were fee-for-service. So whether you're engaging in value-based care or even fee-for-service, you can offset some of it with fee-for-service, and you can look up the details of that. Let's quickly go over the components. Starting at 12 o'clock, we identify goals, but not in the traditional way of just identifying patients' goals. We also have our own goals, and we are accountable to them on a weekly basis, and we check them off. And if we don't do them, if we don't fulfill those goals, we don't close the loop, we have to report why not. And there's documentation of that so that we are accountable. We have used evidence-based behavioral strategies like motivational interviewing, like problem-solving treatment, like behavioral activation. You'll be pleased when you look at the details of the behavioral health codes that all of those methods are suggested in that kind of treatment. We monitor progress. It's treat to target. It's measurement-based care. And then we have the systematic case review that I told you that happens once a week where we review all cases, and I'll tell you more about that. The last thing I want to say about the components is that the PCP is involved on a weekly basis. This is not a siloed program and where the PCP finds out about recommendations in 3 months. Rather, every week they are apprised of any recommendations, curbside suggestions based on the most recent information, and it only becomes an action step, is only executed if the PCP agrees. So that is the way we do it. And this is all nested within a framework where we use opportunity analytics, claims and EMR data to identify patients, enroll them, put them through the program, and then return them to regular care. This is not forever. This is to really bring people back to usual care once they have achieved their outcomes and they've gotten a better handle on their disease and their depression is treated and so on. We can talk more in details. Just a schematic about the systematic case review. If you can't see it, I'll point you to the 2 red arrows. That's the key point. Data in, data out. The data in is the most recent values, maybe weekly PHQ-9s, of course every 2 to 3 months A1Cs, blood pressures possibly on a weekly basis. LDLs, of course, longer. GAD7s could be weekly. Point is, we have data at hand, and we have a systematic case review process. The top 3 people there are the core, psychiatric case reviewer, care managers, and PCP case reviewer, and data out. And that means 1 to 3 action steps conveyed to the PCP on a weekly basis. We review 40 to 60 cases. This takes 1 to 2 hours. And basically, this is population management at its best. We utilize treat-to-target strategies. I just wanted to show you this because this came from Fortney and colleagues, where they looked at Medicaid examples, FQHCs, and used practice-based versus telemedicine-based programs. And what they actually found when they focused just on depression using this collaborative care program is that you actually got better outcomes, lower depression, quicker reductions in depression using a telemedicine-based system versus practice-based. And part of the reason, and we know this from working with many, many healthcare systems, is that there's so many competing demands, so many needs for what embedded care managers are doing in the clinics, that you cannot maintain the skill set and you cannot keep the focus on these highly, highly comorbid patients as a way of getting these outcomes and following the model. Last few slides and then we'll go to questions. We're addressing depression and comorbidities. The care managers learn about psychoeducation, administering screening for comorbid conditions and self-harm, reviewing and titrating meds, addressing side effects, and then evidence-based behavioral strategies like problem-solving, behavioral activation, decisional balance, self-management, relapse prevention. This is all part of what the care managers on the front lines do, whether they're social workers and or nurses. And in this case, with multiple chronic conditions, we use nurses. So in summary, we address depression and anxiety in the setting of comorbid medical conditions. In other words, also addressing those comorbid medical conditions like blood pressure, cholesterol, diabetes. There's been such a focus on the what, addressing gaps. Oh, we are gap, we have been identified. We have all these fancy pie charts. The question is, how do we actually address those gaps? So really what this does is it addresses the how to the analytics what. We cannot close gaps if we don't know how to do it and do it efficiently and cost effectively. The other thing is that we inadvertently continue to perpetuate silos of carve-outs and behavioral health as though that was something that didn't impact medical problems. We have to start addressing health behaviors and not just behavioral health. This is where we need to go, and this is a model that provides health behavior, focusing on behavioral activation, self-management support, not only for depression, but also for chronic conditions. Truly population health, and we address patients based on opportunity analytics and not just indexing them to the time they're discharged. That's a limited model. It's a wonderful model, but let's look at patients in a whole cohort, not just when they get discharged from a hospital or admitted. Again, that's not wrong, and we do that, but we have to expand this beyond just that. The benefits are that patients rapidly improve, we reduce silos of care, we use a biopsychosocial approach, we include PCPs every step of the way. It's a built-in curbside consultation that you get from psychiatry and internal medicine, maybe pharmacy and social work if you add those, and it works. We've proved concept over and over and over. We know it works. So why don't we use something that has incredible evidence base, not only for treating depression and anxiety, but also for treating other medical chronic conditions. I'm going to stop there for questions. Thank you.
Thank you, Dr. Chudovsky. We do have one question for you. What is the health profession background of the care managers? For example, do the care managers need to be a nurse?
Yeah, exactly. So that's a great question. And I think one of the challenges always in implementing this is when you work in a system as opposed to in a clinical trial, you have to go, what are the realities of this system? What is the constellation of providers? And how do we ensure that we get the quality outcomes, achieve the triple or quadruple aim, given the circumstances that we have? And so what we've learned is that you can utilize various constellations of providers, including nurses, or pairing up with social workers or patient navigators. And there's many different ways to do it as long as the fundamental core components are in place and you don't provide the model and have cut corners. So in this model, in the clinical trials we use nurses, but in many, many clinical trials before that, we've used social workers, even bachelor's level providers, and there's all kinds of variations on the theme.
Thank you very much for your presentation. A few closing words from Dr. Mims.
Thank you all for joining us today. We have learned a wealth of information that we can take today and make use of in our healthcare teams. This will allow our patients to be safer and we can work better as a team. Feel free to contact me at my information here if you have further questions about programming for this Learning in Action Network. Please mark your calendar now for the upcoming presentation on March 16, 2017 at our usual time, 12:30 to 1. Plan to join us next month.